Hello, everyone, and welcome to another edition of our Systems for Action Research in Progress webinar series. This is Anna Hoover. I am the co-director of the Systems for Action National Coordinating Center, and it is my privilege to be your moderator for today's exciting session featuring our collaborating research center that is doing some important and exciting work at the intersection of health, public health, criminal justice in the state of Arizona. We'd like to remind folks to please go ahead and mute your phones if you are on the line and not speaking at the moment. Thanks so much for that. I want to remind you before we get started that Systems for Action is a national research program of the Robert Wood Johnson Foundation. Systems for Action examines innovative mechanisms for aligning the systems that support public health, healthcare, and social and community services and supports to support health and well-being for all Americans. The work being done in Arizona through our Systems for Action Collaborating Research Center incorporates expertise from a team that includes Principal Investigator Dr. Bill Riley from Arizona State School of Healthcare Delivery and Dr. George Runger, who is Chair of Arizona State's Department of Biomedical Informatics. Today, we are privileged to have presenting this work with us Dr. Michael Schaefer. Dr. Schaefer is a professor in the School of Social Work at ASU's College of Public Service and Community Solutions, where he also holds affiliate appointments at the Center for Health Information Research and the School of Criminology and Criminal Justice. Dr. Schaefer is the founding director of the Center for Applied Behavioral Health Policy, which has, for the past 25 years, conducted cutting-edge research on the adoption and implementation of innovative practices in behavioral health care. Dr. Schaefer has authored more than 40 peer-reviewed research articles and generated more than $45 million in grants and contracts that target capacity building and innovation in behavioral health services. After we hear from Dr. Schaefer, we will hear from our esteemed commentator for today, Dr. Christopher Maxwell, who is a professor in the School of Criminal Justice at Michigan State University. Dr. Maxwell's research, scholarship, and engagement activities largely focus on understanding and improving how governments and NGOs can prevent and control intimate partner violence and violence against women. Dr. Maxwell's sponsored research projects include several that have examined the benefits and costs of sanctions and therapeutic treatments for spouse abusers, the impact of police and court services on victims and perpetrators of intimate partner violence, and other projects that have measured the epidemiology and control of violence, including sexual assault by intimate partners. Dr. Maxwell's research focuses on assessing the extent to which IPV offenders are prosecuted and convicted and testing whether or not more prosecution and sanction leads to less violence. After Dr. Maxwell provides his thoughts on Dr. Schaefer's presentation, we'll be inviting you to ask questions of both our presenter and our commentator. So we ask during this presentation that as questions occur to you, please do make use of that chat box on your screen. If you will type your questions in, and we will be logging those as the presentation goes on to share them at the end of the call. So with that, I again welcome you all to today's call and hand the reins over to Dr. Schaefer. Michael?
Good morning, and thanks very much. It's a real pleasure to be here today. I want to acknowledge our partners in crime on this initiative, Dr. Bill Riley, who will be joining us a bit later, and Dr. George Runger, who is on the line and will probably weigh in, along with the variety of the other staff that we work with on the project. We set the initiative in Arizona out to demonstrate proof of concept that we could create interoperability between a number of siloed information systems, these systems cutting across healthcare and social service safety netting programs, and then to assess the impact that integrating information systems could have upon the policy-making decision process. And it's important to underscore that the context that we operate in here in Arizona is one that allows this type of research to occur. We structured our project around these four aims. First of all was this notion of creating an integration quotient. By having access to Medicaid claims data, we could begin to understand the relative contribution of claims in the physical health versus the behavioral health area, and that we could do so for specific strata of Medicaid enrollees for our interest, most notably persons identified as seriously mentally ill, folks meeting criteria in our state for what we would call general mental health and substance abuse services, but to be able to use this notion of an integration quotient to assess progress toward healthcare systems integration. Second and third was really to look at, could we then, using claims data and linking claims data with other social service and criminal justice data sets, could we begin to create some predictive models of unplanned hospitalization, most notably ED utilization, and criminal justice system involvement. Last, pulling all these data together and these analyses together, could we create some pretty, if you will, evocative and action-provoking visualizations of our analyses that could perhaps be more policy informing? So what we've been able to achieve and are in the process of developing here is a multi-systems data warehouse. That data warehouse resides at the Center for Health Information Research that Dr. Runger directs. CHIR for many years has received patient identifiable access claims data for the entire state of Arizona through our state designated Medicaid agency. CHIR is also the recipient of patient identifiable hospital discharge data. So the ability to begin to link data systems together. Through this project, what we set about to do is to begin to link in criminal justice and homeless service data together at the level of the individual patient, including booking data into our county jail at Maricopa County, data from our county probation department, and data information from the Homeless Management Information System, the HUD required data set that their sponsors or contractors have to provide. We're working today and we'll be presenting the data that is reflective of Maricopa County Medicaid enrollees during state fiscal year 2015. This time period, 1-year time period, was an important year because it was the first year of a new contract awarded to Mercy Maricopa Integrated Care by our state Medicaid agency. The intent of this new contract was to implement integrated healthcare services specifically for the enrollment population of persons with serious mental illness. Hence this focus around persons with serious mental illness and others not qualifying for that program will be a primary thrust of the information we present today. These data reflect over 326,000 claimants in Maricopa County. Of that, 4.2% or 14,010 were seriously mentally ill. We structured our study again around 4 aims. This first aim was presentation of and development of an integration quotient. And to do that, we began to take a look at claims data for 1 year. And so this line graph that's coming up now reflects the median total claim value per patient in each of 10 cost bands, or what we've labeled here claims deciles. So we arrayed the total claim value for all people in the SMI program and all people in the non-SMI program and cut those into these cost bands and then compared the claim value for persons in the SMI program and non-SMI. And you can see that as we tail up toward the higher cost bands, we begin to see some split, but up through about the 5th decile, really not too much difference in how the state Medicaid agency spends. We're going to zero in on the 5th decile, and we're going to compare the type of claims allocation, bucketing things into these categories of physical health, behavioral health, and pharmacy. What you see here on this graph is for the non-SMI folks falling in the 5th decile. You'll see in the physical health area claim value at 4,541 individuals, that 84% of the healthcare spend for patients in this decile were spent in the physical health area, and that 99.81% of the non-SMI claimants in this decile had at least one claim for physical health. That helps you kind of organize around those three numbers under those labels. So this is the non-SMI fifth decile. Take note, 84% in physical health, 6% in behavioral health. As we now look at the SMI population in that same decile, we see that physical health cost has dropped to 36% and 45% for behavioral health expenditures, with a jump likewise in claims for pharmacy. If we jump up and look at the most costly group of Medicaid claimants, those in the 10th decile, we see that for the non-SMI population, that physical health care cost at this decile, highest cost band, is now representing 69% of all Medicaid claims. Behavioral health, interestingly, has jumped to 11%. As we compare this to the non-SMI population, we see physical health expenditures shrinking even further to 20%, and behavioral health-related claims exploding to 58%, and a continuing good share at 20% in pharmacy. These data here look at the deciles, and what we've done here is create what we call our integration quotient. The integration quotient is ostensibly the ratio of behavioral health claim value to physical health claim value. And we've compared these ratios for patients in each of the 10 deciles. And so as the graph notes that for people with serious mental illness who are falling in the fifth decile of expenditure, for every dollar claimed for physical health, $1.28 was claimed for behavioral health services. And then in contrast, for people with non-serious mental illness in the most expensive cost category, we're claiming 2 cents. We're seeing 2 cents claimed for every dollar of physical health expenditure. We take a look at these same claims disease data by disease code. And so what these data represent is the percentage of patients having at least one claim associated with at least one of these illnesses or conditions along the left. And not surprisingly, we see that for individuals identified as seriously mentally ill, 80% of them had claims associated with treatment of psychotic disorders. Interesting differentiation and spike in the area of musculoskeletal connective disorders, perhaps attributing to some of the pain issues often associated with psychiatric disorders. Some interesting differences in endocrine, et cetera. But across the board, perhaps a bit more noise in terms of the healthcare system trying to treat a variety of conditions that these patients are reporting. However, when we look at the claim value, how much money is being spent per patient on a claim, we see some interesting patterns, most notably, and not surprisingly, patients with serious mental illness having greater claim value in the treatment of neurotic disorders and psychotic disorders. Not a surprise there, but then across the board for every other health condition, patients who are not in the SMI system, not identified as seriously mentally ill, their claim value exceeded that of their SMI counterparts. It's interesting to note given the attention to comorbidity of mental illness and substance abuse, that the claim value for people who are not in the SMI system was actually greater than it was for the SMI population. When we look at claim analysis by procedure code, so this is looking at the same claim, but what was the procedure that was being treated? And just to make sure everybody stays awake, we have reversed our color code here. So here, SMI patient representation is in the red, the non-SMI is in the blue. And what's noted here is that median patient claim value was greater for patients with serious mental illness in the areas of non-emergency transportation, personal care services, pharmacy, mental health, not surprisingly, respite care services, hospice home care, and assisted living. That last one relates to some of the other policy issues we see occurring in Arizona around housing, hospital boarding, et cetera, with this population. We're now going to take a quick look at some of the data we've been able to pull together in the area of hospitalization. And our aim here was to see if we couldn't begin to identify some patterns of patients here. So what you're looking at here is claims for emergency department, and you're going to see in the top set of graphs the median number of claims for patients who were not seriously mentally ill in the red, and people who were seriously mentally ill, the median number of claims, the median number of claims that were for behavioral health, and the median number of claims that were for physical health. In the bottom graph, we're presenting the median claim value contrast here. And so again, what we see here in terms of the emergency room participation, non-seriously mentally ill patients had 8 median claims of emergency department utilization compared to 5 for folks with non-serious mental illness. When they got to the emergency room, people with serious mental illness cost the system on average 60% less than what they paid in treating people who were not seriously mentally ill. This is in part the penetration or lack of penetration. We were surprised by these findings on emergency room. It's reflective, though, of some terrific long-term development in Maricopa County of diversionary systems for psychiatric crisis. So Maricopa County has a well-integrated information call-in crisis response system that's linked to first responders, and we also have throughout our county a series of psychiatric urgent care centers fully licensed and serve as an alternative placement. We look now at the inpatient claim data. Again, what we see here is greater rates of participation in claim activity for inpatients by patients who are not seriously mentally ill. And again, very sharp contrast on the median value of claims for patients accessing this service, including, ironically, in the area of behavioral health services. These are some early data that we played with here, and what I want to orient folks to are the graphs up at the top. So we're back looking at our 5th and 10th decile. Folks, these are the 5 most expensive claimants within this 5th decile who were seriously mentally ill. So these are 5 folks within the 5th decile, and the data down below just gives you some general descriptors. But conceptually, what we're beginning to work toward is a timeline chart that allows us to understand the relationships visually between emergency room, jail, pharmaceutical claims, et cetera. So very conceptual work up on the 10th decile, but note the concentration of the green behavioral health services in the second line that you see there, and the consistent but sparse pink in the bottom line representing physical health. The reds here reflecting emergency room, and then this next slide contrasts with folks in the 10th decile, and you'll see how much denser those graphs have become and how much denser they've become with green and blue. We expect to do more work with some of our other colleagues at the university in the next year in how to make these type of information more helpful. Very quickly, another one of our aims was to see if we couldn't begin to develop some predictive models around criminal justice involvement. And for this, we're looking at jail data and probation data that we're able to link with and join to the claims data. So we've had some challenges in accessing our jail booking data directly. And so what we're relying upon actually is an innovative strategy of secondary data capture that George and his colleagues were able to come up with, that we're scrubbing data actually off of a bail bondman's website here in Phoenix. It says something about the bail bond industry, that they have better data or more accessible than our jail system, but we won't go there. So what these data show right now is the mean, median, max, and then rate per thousand of arrest among patients who are SMI only. We will be adding to these data the non-SMI data comparison in the weeks ahead. These data are interesting. They come from our county probation department, and what they reflect is a comparison between the number of patients in the access system, non-SMI, who are enrolled in the probation department, and it had what was called an OST, an offender screening tool, which is their risk assessment tool listed. And you'll see that we've got about 2,700 non-SMI patients in the probation system, and we've got a little over 1,000, I think about 1,100 SMI patients in the system. 8.47 of the SMI claimants are co-enrolled in the probation system, compared to less than 1% of the non-SMI population. Their relative risk band scores reflect that the patients who are socially mentally ill are 3 times more likely to be classified as criminologically at a high risk and requiring a more intensive level of supervision than the non-SMI individuals. Part of our work ahead is to look at how those risk scores relate to packages and value of Medicaid claims data. Is there multi-sector responsivity relative to criminogenic risk? So this table summarizes simply the percentage of patients, non-SMI and SMI, that had at least one emergency room department claim, 67% for the non-SMI population, compared to 49% for the SMI population who had at least one inpatient claim, 46% for the non-SMI, 26.85% for SMI. We're currently working on the jail booking data as are reflected, 0.88% non-SMI in probation, 8.47% for the SMI population. On Monday, we'll be meeting with the Maricopa County Coordinating Care Committee to negotiate access to the Homeless Management Information System. Our last aim of this project was to transform our proof of concept analyses into visualizations that can facilitate evidence-informed and actionable dialogue and decision-making between multi-sector policymakers. And for this, we're teaming up with our colleagues at the Arizona Decision Theaters, experts in taking data and creating more actionable and more real-time opportunities for us. Some of you have had the opportunity to come and visit our Decision Theater in Tempe, and we look forward to moving into this stage. So in conclusion, what these data begin to tell us is that compared to people who are not seriously mentally ill, patients who are seriously mentally ill generate comparable total healthcare claims value up through the middle of the pack in terms of expenditures at 5th decile, that they generate markedly lower value health claims at decile 6 to 10, and that they receive significantly more behavioral health care, less physical health care, less ED, ER services, and less inpatient services. Our next steps is to reevaluate the metric for creation of some of the strata and deciles. We see linking the jail booking frequency data and some of the risk data to the claims data to be very informative. And looking at some of the relationships between the patient characteristic data we have access to and claims patterns, and then begin to see if we can't begin to replicate some of these analyses for some other target populations. We're continuing to receive access to and securing additional data sets, and are at a point now of beginning to, I think, move forward to some meaningful discussions with our colleagues in the decision theater on the build-out of these visualization platforms. With that, I'll conclude and open up for questions or comments, I guess, from you, Christopher.
Right. Thanks so much, Dr. Davis. We're going to transition over for commentary in just a second. We do have some questions coming in on the chat box. Please continue entering those into that chat box entry form, and we will get to those in just a few moments. And I now turn control over to Dr. Maxwell for his comments.
Good afternoon, everyone. I don't know if I have control. I wouldn't want to take on that responsibility. But thanks for inviting me to give some comments, and I appreciate the opportunity. First is this: there's a whole lot just to take in from this brief presentation, particularly from a criminology point of view. The whole idea of data integration has probably been at the center of what criminologists have been trying to do for 25 or 30 years, and to see other fields get involved in that is very exciting for us. And I will comment, though, that your frustration to get access to booking data, it doesn't surprise me at all, because on what part wasn't mentioned part of my bio is we have a 9-city program of research going on right now trying to integrate criminal justice and social service data together across multiple sectors to focus on identifying the most at risk women to be killed by their husbands. It's a national demonstration program by the Department of Justice, and probably the most frustrating part of our work, for which I think we need much greater dialogue among people in this group and other groups, is the fact that instead of getting greater access and transparency to information systems, the information systems across the United States are becoming more hardened and impenetrable by researchers and people who are trying to make change. So that doesn't surprise me. In our project, we are getting access to booking data. That's not been a particular problem. But on the other hand, we're not getting access. For example, New York City was part of the program, and they immediately said, well, you can't have access to arrest data because arrest is protected information. So I think going forward, we're going to have these systems that we're creating, these demonstration systems, will have difficulty being implemented from place to place. And I know the last goal of your program is to try this in other parts of Arizona. It will be interesting to see what would happen when it was tried in Charlotte, North Carolina, or in Jacksonville, Florida, where a whole other set of political issues come up. So I guess one of the first comments, just kind of questions, is in the period of time that this project has been going on, and the results are very interesting. But I guess part of what I like to understand more of is what were the political barriers that people had to overcome, and what were the ways to solve them to get access to even the data that you have, and what are all the data that you tried to get access to, but you couldn't because the doors were shut, even though originally people may have said, oh yeah, you can have access, until you described to them the kind of access you wanted. So I kind of, I don't know if this is the way we can do this, but I don't know if you can talk about or respond to sort of what didn't we see that you wish we could have seen, but you were stopped because the politics of Phoenix in the county that you work in. So I don't know if you can respond a little bit to that question now.
Sure, I can. And George, I don't know if you want to jump in here as well. Feel free to do so. But I think it's important. The context here in Maricopa County and Phoenix, I think, is rather unique, and part of it owns to this long-standing relationship that George and the Center for Health Information Research has had with our state Medicaid agency of sharing of information. Paralleling that, though, is the work of this group, which has very much been at the intersection between the publicly funded behavioral health system and the criminal justice system. And so goodwill there, if you will, and I think great cooperation and collaboration, more so on the probationary side of the equation and less so in the first responder jail court data. Those data particularly have been very difficult to gain access to, and I'm sensitive to the inadequacies in data tracking systems, particularly in the criminal justice area as we move across communities. But generally the collaboration, cooperation for data access here has been surprisingly and pleasingly positive with us, with these exceptions on the court and booking data.
All right. So similar. One of the comments I was writing down was, you're looking at booking data, but booking might represent 10% of the population that the police come into contact with. So I was wondering whether you had tried to get access to the field notes of police officers.
No, we have not, and I don't know that given the resource demand on that, whether we go there. There are, however, I would mention a number of additional data sets that we have on the horizon to bring in as we continue to build this out. One of the things I noted is the relative lack of ED, of emergency room claims among the SMI population, and noted that of what we have, some of the political context here in Arizona has been a very strong working relationship between law enforcement and the behavioral health system around crisis intervention team training and information sharing. So Maricopa County has a very robust diversionary program to ensure that folks don't get booked into jail or don't show up in the emergency room through psychiatric urgent care centers. The billing data from those psychiatric urgent care centers, the number of drop-offs that come into those psychiatric urgent care centers from first responders, law enforcement officers, are some of the data that we have on the horizon to acquire in the months ahead.
Yeah, and literally when you were showing that screen or the results, that sort of came to, and you described it, it did sound like a problem that you've identified, which is a selection problem. Essentially, they're being selected out of the system or diverted out of the system, and you're actually measuring a positive impact. It looks like it's worked because you would have expected it to be much higher number of claims. Right. And so, if anything, this project alone has demonstrated unintendedly demonstrated that the diversion has probably resulted in some positive outcomes. So I think I'm always excited to see opportunities to link data. So one of the things I wrote down too was about what were the barriers. So you just answered part of my question. Is you have access to identifiable data. Are the participants consenting? So are the participants consenting to that?
No, George. I'll ask George to step in. The Center for Health Information Research. George, are you open? Are you on?
I am. Yeah, I'm on. We've had a long-term working relationship with the state Medicaid agency where they do provide us with identified data, it's in HIPAA secure facilities, and all of those, all of those provisions are in place. And for research purposes, we're approved for the work both through an ASU IRB, and then a separate approval is required from the state Medicaid agency for using the data for these purposes.
So ironically,
and so the identifiable data gets linked at CHIR's office, and before we do any analysis on it, all that identifiable data, once the links have been made, then the identifiable data gets stripped out for analytic purposes.
Right. So one of the ironic things I have found now doing this work, that it turns out that most people's concern about HIPAA, which there might be very serious concerns about, that actually on the flip side has provided a structure for actually sharing data. Because as you probably realize when you went to the police department and the booking people, there is no systematic structure in place, no standards or guidelines, and they look at you with great amount of dismay when you ask for identifiable data, because there is no formula for them to move forward with that request, because they're not sure who to look to or what standards are there to use. So in some ways,
maybe this was George. I was going to say is, I agree with what you're saying, and we use the state Medicaid agency as sort of the precedent along those lines to say that we're going to deal with new data sets in the same manner that we've dealt with that data set for almost 20 years now.
But on the flip side, you have the FBI, for example, working in the background, who are encouraging police departments not to share information because so the FBI, for example, has put up a sort of a national-wide policy that you cannot share criminal justice data with anybody. I don't know if you're aware of that.
No.
Yeah. So, for example, the National Archives of Criminal Justice Data had to pull down all their existing data from the archives that may have or does have or could have or thought to have anything to do with data that may have been collected or have access by the FBI. So one of the things that's going on is you might be running into the jail people are turning to the FBI. Well, are we allowed to share this information? So there are, and this has been going on for about 4 years. This is not a new event. I mean, on our effort to integrate data across criminal justice system information so that we know who, for example, who has restraining orders, that's been prohibited. There's lots of people working in the background.
Well, I think the contrast, one of the things that I'll put a shout out for the state and local governments here, though, is their investment in information technology. By and large, has been pretty good. The lack of direct access to the jail booking data here wasn't due to lack of the data in a structured format. It was just that the year that we were looking at, correct me if I'm wrong, George, they'd already archived their records. And so to pull those data up was something they weren't willing or able to do, and we hadn't planned for it in our budget. But they do have a pretty solid IT system. And in the years I've been in Arizona, it's been one of the things I've been struck with is a general solid structure in personal level identifiable data systems across agencies.
Yeah.
And I know the booking data.
Yeah, that doesn't surprise me. I mean, Maricopa has been involved in some of the best research in criminology for 25 or 30 years, in part because they have had a big investment for many years in good information systems. Right, to facilitate access, to facilitate data collection. So it doesn't surprise me. It just increasingly across the country we're becoming less able to access those better systems to do the things that you're trying to do, which is to integrate with other systems, right? medical health records, ER, to provide a more complete picture of what's going on, right?
One of the things that I think we have the potential for in this context, I'm struck by the risk responsivity principle within community corrections and corrections in general. And is there a demonstration of a risk responsivity relationship here between the kind and amount of behavioral health care that individuals are getting and their relative criminogenic risk? And I think that's the ability to link those systems together and begin to understand potential cause-effect correlational associations between untoward, undesired penetration into the criminal justice system or the ED system as a function of behavioral health care, I think is one of the exciting opportunities we have.
Well, yes, I think that's absolutely true. And the system has the area of risk assessment for probation work is pretty well developed, has been since the 1970s with work by Todd Clare and other folks. And so, but what we've often lacked the field is dependent variables, and what your system is potentially providing is a much more broad set of dependent variables that allow us to not only estimate what an intervention with our probation department might do on criminal justice behaviors, but also on all the other things that happen between the time the police get, or before the police ever get called, right? Or whether the probation officer ever trips across the violation. And it looks very exciting to, as a criminologist, to look to see what you're doing, and your mind starts wandering about all the things that could be done. So one last question is that, is there a plan to make this data publicly available?
George?
Well, in aggregated forms, the identified data that needs approval from the state Medicaid agency. We can occasionally, they will sometimes approve limited data sets, that are focused on a particular project. They have not in the past approved sort of an open, sort of investigation into the data where it's not predefined specifically what the objectives are and things.
Given all of our field's inability to reproduce other people's results, is there concerns that this might not be moving us in a direction that would improve our reproducibility?
I'm not quite following your question.
Well, so my concern, I guess, is that you're developing this as a very good, sophisticated system, but then the rest of the field has to rely on a sort of a trust me, because we can't reproduce your results. So
well,
are we going in
I'm not sure it's the results you reproduce as it is the infrastructure to the extent that you're able. That in most communities, right, so the Medicaid, using the Medicaid claims data as your foundational base is pretty constant across the states, right? So if you can start there and then begin to do some systematic analyses of what access to other social service system data is available into your communities, and to what extent can you bolt those on, if you will. I think that's the important reproducibility element.
Well, that's a question of replication. Can we replicate this in other states? I was questioning about reproducibility of what you're finding with your own data, whether people
Well, to the extent that a limited data set for a specific project is presented, that's the kind of thing that the Medicaid agency would normally agree to allowing, that kind of data to be released. So it's, subject to those sort of constraints, it is possible.
Because I think that's what we also have to be careful as we link all this stuff together, that we don't inadvertently actually make it more difficult to reproduce our science. Right? We want to be able to publish this stuff, and we can't publish it if we can't put the data sets up. Right? There's increasingly a requirement to make data available at time of publishing, so that other people can move and test whether that actually is indeed what the data support. And so I think as we build these systems, we need to put into them the mechanisms to say we can't move forward with this project unless everybody can have access to the data. Because that only puts up sort
Indeed.
of...
Indeed. And it underscores some, if I can, Chris, on that, it underscores some of the driving principles behind the way that we organize the project. The issue about equal access to the data and equal sharing of the data from our local stakeholders was a driving principle. That is, if you as an agency stakeholder are willing to trust us with your data and to commingle those data with other agency data, we begin to create a space for multi-sector policy discussion to occur. And that's really the next phase. That's that fourth aim on this project. The first aims have really been about, let's get access to the data from across the systems. Let's see if we can't connect them together, and then what do we make sense of that? As we move forward in the next few months, we'll be putting together some design workshops to bring together community stakeholders in state to begin to design out what do these, if you will, dashboards need to look like in visualization. Equal access to the data among our community stakeholders, those that provided the data, certainly is a driving element of the way we design our program here. The issues around broader replication issues for research purposes of secondary agenda, I think, right now.
Well, and I do, I wrote down the theater concept, and I think that's certainly a noble operation or attempt, because as researchers we often get criticized for not bringing our data to the table, to the policy table, and certainly that's a good opportunity, and that I look forward to watching and learning how it gets developed and seeing whether we can replicate that in other places. And I guess I would, of course, still emphasize that at some point we need to be able to, at the same time people are closing down access to our data, we need to push back on that by demonstrating that we're going to provide more access to the data that we do have. Because we can't complain that the probation department isn't giving us, or bookings aren't giving us the data when we don't turn around and provide the data that we do have to other people. So I think we got to work together to both demonstrate good social behavior, good civil behavior, while we actually at the same time push people to share more of what they do have. I gave a presentation a couple, But anyway, I was just going to finish. Yeah, go ahead.
Oh, go ahead. No, please finish.
I was just going to say, I just a final thought. I was asked to give a presentation to argue why universities were so difficult to work with for research purposes. They won't allow us access to the data. But I demonstrated that 32 of the researchers in the room, all 32 had not shared their research data with anybody else. So before we begin to complain about who doesn't allow us to have access to their data, I'm trying to push that we ought to allow more open access to the data that we do have. So anyway, that was my final comment.
Thank you so much, Dr. Maxwell, for those wonderful thoughts. I hate to cut this discussion short, but we do need to get to a few audience questions. And I feel like in his last comments, Dr. Schaefer was pushing us in the direction of some of those questions. I do want to get there, but I want to comment quickly that this has been a really interesting and invigorating and exciting and illuminating discussion we've been having for about the last 20 minutes, and really is one of the goals of the Systems for Action program is really to, you can only identify the challenges that you are aware of within your own sphere. Challenges and opportunities that I see are limited to some extent to my training and the information sources that I consume and my disciplinary predilections. So in talking with folks from other disciplines and thinking about how these systems can link, when we're thinking about how systems link up, we have to have these discussions across disciplines and across sectors to really bring to light some of the potential challenges and some of the tremendous opportunities, whether we're talking about information sharing, reproducibility, or translation of findings. So I think that this has been a really exciting conversation because it is one that I feel like of our Research in Progress webinars has really exemplified that kind of give and take discussion that we're going to need to advance this field. So I want to thank Michael and George and Dr. Schaefer and Dr. Maxwell for their thoughts during this really exciting discussion. But I do want to touch on a few questions that have been coming up in the chat box. And they relate to translation and that decision theater concept that Dr. Maxwell referenced, that Dr. Schaefer referenced, that we were talking about a little bit. I think the conceptual work that this team is doing on the Integration Quotient is really very exciting in terms of addressing the systems part of Systems for Action, right? We're getting the information we need on how to better align these systems. But in terms of the action component, that decision theater is going to be critical for translatability. So I'm hoping that Dr. Schaefer, Dr. Runger, I don't know if Dr. Riley is on there, but if you all might talk a little bit more about that decision theater, and particularly a couple of pieces. In our visit there, it seemed that systems dynamics, network analyses, those kinds of pieces are really important to how that theater works in terms of spurring, prompting stakeholder discussion, prompting stakeholder consideration of issues. So I'm wondering if you can talk a little bit about these data and how you plan to put them together through system dynamics, modeling, network analysis, other ways to help folks think through these problems. I'm also interested in in what stakeholders you expect to be in the room once you have those prompts ready to spur discussions, and what kinds of decisions might they be thinking through? So I'll just
Sure.
ask that broader question about the decision theater and translatability. Thanks.
Terrific. Thank you, Anna. George, if you don't mind, I'll take point and but join in as needed. Picture down in the lower right on this slide is a picture of what's called the drum. The drum, as you can see, can accommodate comfortably about 15 people in that kind of table configuration. 270 degrees visibility in the drum are these large screens. So there's a massive kind of computing back end to this environment. And the other shots that you have here are simply data arrays. And what we've been able to begin to do is to assemble these data arrays and begin to think of different layers of data. When I've seen the decision theater used effectively, it's bringing together multi-agency stakeholders. So in our context, folks from the courts, from the judiciary, from probation, from pretrial services, from first responder law enforcement, EMT, from our Medicaid agency, other providers into this environment, and having our data arrayed in such a way that allows for, if you will, real-time hypothesis testing. Hypothesis testing that allows us to associate different client, service delivery, and service involvement indicators together, and to be able to bring those data up in relatively rapid fashion, arrayed in some form of visual dynamic that allows the 15 or so people in the room to engage in a data-informing policy discussion. We expect that bringing those stakeholders together and creating this kind of space for policy discussion using data that their systems and agencies have provided to us already will lead to greater collaboration among those stakeholders, greater communication, and more aligned policy making that cuts across these multi-sector systems. It's taken us a while to begin to get all of our data arrays together, much less to begin to understand what those data are telling us. And so we've been a bit delayed in beginning some of our engagement with our visualization colleagues, but anticipate that's on the horizon this year.
Thanks so much, Michael. That's really exciting to hear. I do want to quickly get to a couple of additional questions we've had from participants on the phone. One,
I can see them on the Q&A bar.
Okay, but everyone can't, unfortunately. So I'm going to quickly read through them. Is the higher risk for SMI adults definitional? That is, do the risk factors for criminogenic risk include SMI diagnoses?
There is a mental health item in what's called the OST, the Offender Screening Tool. That is a validated risk assessment tool in place in Arizona. So there is one item, but I don't believe SMI eligibility in and of itself is a distinct factor in their criminogenic risk score.
Thank you. The next question is, does your state include psychiatric hospital discharges in the discharge data?
George, would discharges from Arizona State Hospital be included in our claims?
It would be to the extent that the Medicaid agency is paying for them. And the discharge data set, the other data set we have, which is the hospital discharge data set, does include those hospitals.
And finally, could the speaker address some of the financing options for developing and implementing interventions based on this data? Do you know yet how, we've already talked about how you plan to use it to some extent, but could you at least address some of the financing options for developing an intervention and implementing interventions based on this data?
I could say one word.
Please, George.
The one word I was going to say, it goes back a little bit to the decision theater and some of the modelings that we're planning there, and that is, as Professor Maxwell mentioned, it looks like the crisis response network within Maricopa County is being effective. And so you could look at, for example, interventions where that is even made more robust. So hopefully you can reduce ED visits and inpatient visits further from some members of the population that would benefit more from the crisis response network type of approach. And so in the modeling arena, that's sort of a diversion that should have an accompanying cost reduction. There's slightly more costs in the response network with hopefully much fewer costs, lower costs in the healthcare areas. And so that's sort of a little bit of the back and forth trade-off that we hope to achieve with the decision makers and the policy makers to allow them to suggest some of those interventions and then look more or less in real time at some of the cost savings that are possible. Or at least
Thank
cost
you
impact.
So much.
Savings or not.
Thank you so much, George. I want to take a moment here. Our time has expired, but I still want to take just a moment to thank again Dr. Schaefer, Brucker, and Maxwell for spending some time with us today, for sharing this exciting work and providing important feedback and considerations for the Collaborating Research Center to be considering as they move forward with this work. I'd like to remind folks that if you've enjoyed this webinar, it is part of a series of Systems for Action Research webinars. The website URL is right there on your screen with the upcoming webinars. We hope you'll join us for some of those. We also have contact information for you. If you have any questions, please do not hesitate to call us. Send us an email. Let us know what you're thinking of the Research in Progress webinars. We are looking forward to hearing from you and wishing everyone a terrific day. Thank you again for joining.